All right, so we're about to start with the last debate of today. Thank you so much for still being here. I know that it was a very heavy schedule this afternoon. It's quite tiring, but also very interesting so far. I'd like to really thank from the bottom of my heart all 5 participants to that final panel, and I'd like to underline the fact that it's not every day that we have a group with 5 experts that are, such high quality people. And I'd really like to thank you all for being here, all 5 of you. I am going to give a brief presentation to introduce them briefly. I'll start by the person who's right at the left, Mike Trace, who's from the UK. He has a European career. He used to be the head of the European Office of the fight of drugs, so MCDDA in English, and he also occupied similar positions to that of Dr. Gozlan in the UK for years on end. He is the general manager of the Forward Trust, which used to be RAPT, which manages management centers in prisons, and I could give his whole CV, but that would be it would take quite a long time. He's spent 25 years helping people suffering from addiction. So thank you so much for being here, Mike. Thank you very much. I'll move on to Mr. Michel Reynaud, Professor Michel Reynaud, who's a university professor, a major stakeholder in the fight against addiction in France. In his psychiatry department, he's also very invested, very committed to contributing to several plans. He's participating in the Mildeca. He's a very innovative stakeholder as well. He's been working for the Addictions Fund, and he created the Addicted Village, which is a web portal which I believe is really efficient, really good. It's a very good address. Then there's Dr. Ruth Gozlan. You know her already. Thank you very much for staying. Jeanpierre Couteron as well, President Couteron of the Addiction Federation. I mentioned his fantastic intervention in Le Havre last summer, so thank you very much for being here as well. For our English speaking friends, the Addiction Federation is probably the biggest federation for addiction professionals, with congresses, training sessions. We have a newsletter in order to broadcast our message. It's very interesting, and it's very big in France, so thank you very much for being here. And finally, Jack Charlier, who comes from Chicago. He comes because he is pushing a very important initiative in the US together with other people, like my colleague here at the left of the room. And that has to do with the revamping and the recreation of the American system between criminalization and repression and help and care. So they work together with judges, people on the field, first responders, and I mean, they've noticed that the policy so far is not really working. There are very innovative ideas, similar sometimes to what was mentioned already today, but we thought it was very important to have him today in order to get a breath of fresh air and maybe to get a different perspective as well. You know, the sun rises in the east, addictions rise in the west. We know that we've had a lot of opiates, a lot of trafficking for the past few years. There's a kind of an anti, rotational force on planet Earth as far as addictions are concerned. So we'll listen to what Jacques has to tell us. But again, the idea is to have a debate and to be able to share ideas. The idea is not to have a fight. The idea is just to have a discussion. I hope you will agree with me when I say that the idea is that 16, maybe 18% of the population is a victim of addictive disorders in the West. We hear about it less in the newspapers. It's an object of shame. It's something that we're not happy about, that we're embarrassed about. It's a good thing that we do have some private actors, some people who take into account that ocean of human suffering, and there's no reason that we should accept that 20% of the population should be should be left on the side of the road. They are criminalized, rejected, humiliated, imprisoned. 20% of the population has problems or issues with addiction. We need to rethink our social models. We can't solve that problem by criminalizing those people or by imposing fines or by imposing humiliating moral segregation. This is my point of view. I hope that we all share it in this room, but sometimes also it's all three. They're criminalized, isolated, and so on and so forth. So I really wanted for our last debate to be a very constructive debate. Do not hesitate to take the floor to tell to say what's working well and what's not working so well and what we could obviously do better, so that we can leave the room with hope. I'm going to leave the floor to Jack now. I just need to open up the right PowerPoint presentation. All right, well, while he's doing this, I'm probably going to just start. I'd like to thank Christophe. I'd like to thank everybody for sticking around, staying here. In the US, no one stays after 5 p.m. because 5 p.m. is dinner time. So it's like a setup. We call that we call it a setup in English. So the people who take the floor at the end of the day, it's setting them up for failure because nobody stays. So I have to speak really fast, I know, because everybody's hungry. You can see that I speak French. My last name is Charlier. My father was born in Antwerp. He now lives in Brussels. But Christophe told me, Jack, actually, your French is not quite good enough for you to give a full presentation in French. You make too many mistakes. I think he's crazy, but I also think he's kind of right. So I'm going to start speaking English now. And if I make any mistakes in English, then it's on me, 100%.
Good afternoon, everybody. My name is Jack Charlier. I'm very excited to be here with you today, and thank you so much for the invitation. For all of us who sat with headphones on all the way through until now, the roles are reversed. It's your turn to listen through headphones. Exactly. So good. Well, let me get going. I'm going to insert some items into the presentation that were not there that will add just a few minutes of time, because I want to respond to the outstanding presentation that Dr. Gozlan did and some points that I wrote down that fit with what I'm going to talk about. So you're going to see me flipping through some slides. It's not because I've never presented, it's because I wrote some notes on some things, and I want to try to correlate that to what she mentioned on mille d'écart, right? So that I can say here might be a point where what I'm going to talk about in the United States might fit for France. And I'm certainly not, as an American, coming here to tell France what to do. That's not what I'm doing, just saying where there are points of overlap. So let's get started. In the United States, there is a newly emerging field and profession that we call pre-arrest diversion. And pre-arrest diversion is the linkage in the United States of public safety, so police, right? Primarily police, law enforcement, the different terms we have for that, and public health, going together like this. In the U.S., that has, like many countries, been a problem. That has been a challenge that the two worlds did not come together. But I'll go into later why that is. So what I'm going to talk about is a public health solution that actually promotes, based on research and science, better public safety. And some of this, of course, you know, and I'm well aware that some of what I do will not make sense for the French context. I understand that, but we thought that it'd be good to kind of see how much of this could be useful to you. So, public health approach to better public safety. By the way, if there's any errors on this, that's Christophe's fault. I want you to know that, right? Just want to lay the blame clearly where it is. No, Christophe, actually, I do want to say thank you. I said thank you for allowing me to be here. He put a lot of time in translating the slides with words that we weren't sure how they fit, so thank you for that, Christophe. You did an excellent job. So when I talk today, all these terms that you see up here, if I move in and out of these terms, they're all the same, right? This is a newly emerging field in the United States. We have not agreed on very much yet. So if you ever speak to any Americans other than me about it, they use any of these terms, they're all good. Doesn't matter which one you use, okay? By the way, I don't read slides. That's your job. I don't read them. I just kind of say a few things, so got to go from there. Okay. So what's going on in the United States now? This is a picture, very simple picture, of the United States criminal justice system from your left, right, à gauche jusqu'à droite, left to right. In the United States criminal justice system, up until this time, which really is just a few years ago, the left side represents what we call the front door of the justice system, right? The only way into the American criminal justice system is through police, through law enforcement. That's like that in most of the world. So up until now, all the efforts that have gone on to the right of the police, so the police are on your left, all the efforts that have gone on to the right, jails, courts, probation, prosecutors, prisons, parole, all the diversion efforts, all the programming has suffered that the numbers of people in the United States that those programs have received have overwhelmed the justice system. And we've become poor and bad because of it. In other words, the system can't function the way it is. So while I open up by saying this is a public health approach to better public safety, what is also going on is pre-arrest diversion is allowing the U.S. justice system at the very early stages, right? This is new, to get a handle on the front door and begin to close it so that as many people as possible eventually do not come into the justice system and remain in the community to get treatment or get nothing. They'll do better. Because when they come in, the research is clear, they do worse when they come into the criminal justice system. Even a short stay of 1 to 2 to 3 days begins to raise their recidivism rate because of the exposure to the trauma and what it's like in jails and prisons is bad, right? You guys all know that from the work you do. But what's also true is all those programs at the court programs that are designed to take 20 people in now have to contend with 80 people coming in. So they get worse. Their outcomes, based on the research, go down. Or they have to be these really small efforts that never can scale up, right? Scaling up so that you can take people in. So that's the first point to kind of consider here is, yes, it's public health, it's public safety, but it's relieving the pressure on the courts and the prisons and the jails. And in the United States, not only does that allow then the courts to do more work and better work because they have less people, but the treatment that goes on in jails and prisons, which in the U.S. is about 11% of the population that goes to jail or prison gets treatment, and it's bad treatment because the setting is wrong, right? You're in a place where you're trying to survive, not get killed, not get sexually assaulted, and you're supposed to go to treatment 1 day a week in a jail. That's ridiculous, right? That's ridiculous as a notion. So what it will allow to do is also then allow the prisons and jails, just like the courts, less people, better use of resources, and increase and get better outcomes. That's the big picture of what's going on here in the U.S. criminal justice system with the change. Less people means you can do more with the fewer people that you have that you've designed programs to do and get better outcomes on the back end. Okay, so pre-arrest diversion in the United States. And Christophe, I see a lot of people taking pictures. That's super cool. You know, the slides are available and stuff like that. So however you want to do that. Oui. 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 Si vous prenez les photos, prenez-les de moi. Bon, OK. Si Christophe, je peux faire ça. Oui, en français. OK. Bon. So there's 3 options, or up until now, there's been 2 options for police in the United States, probably same as everywhere else. They can arrest you, or they can let you go, right? They can let you go. Now with pre-arrest diversion, they have a 3rd option called diversion, diversion. These are some of the things that are going on with diversion, and to hit some of the points that Dr. Gozlan said, like I said, I don't read slides, but I want to point a few things out on here. So first one is the systems approach. I'm not talking to you about a program or training or a manual you open up and do. I'm talking to you about how 3 systems relate to each other. The U.S. criminal justice system, the U.S. treatment system, and community, right? Citizens, neighborhoods, folks who are impacted by crime, people who are in recovery. How do they come together? So this is a systems approach, and when Dr. Gozlan spoke, she spoke of a regional and interministerial, right? This need for cooperation among government actors and public actors, private actors to do that. That's what this is. I'm not describing to you the programs that exist that are pre-arrest diversion, but a system of relationships that have levers and funding and political authority to them that allow us to change practice in the long run. Second one, she mentioned here, what I'm going to present to you, and again, it's just a few slides, is about research and science. In the United States right now, the researchers in criminal justice are rock stars, right? They're like Bono, right, from U2. They are the rock stars. We don't move very fast in the U.S. if our researchers don't tell us what's going on and how we should move left or right. So a lot of this has got good research underway. Dr. Gozlan also spoke about legal stuff. Let's see, there we go. So in the United States right now, okay, that's not working. Maybe it is, okay. Forget it, that's not working. Bottom left, where it says une première étape. So in the United States, the first two pieces of legislation at the state level, there's nothing federal. I know France's government is different. There's nothing federal. The first two pieces of legislation at the state level were introduced just this year, January and February in Georgia and Illinois. So we're beginning now in the United States the legal framework to do pre-arrest diversion at scale, right, from a systemic approach, not just police departments deciding on their own, which again in the U.S. police chiefs can decide on their own what they want to do, that a police department will do this, or that a treatment provider says, I want to go and I want to start pre-arrest diversion and I'll go meet with the police chief and we'll do it. So we're starting the legal framework, and she spoke about that, kind of what does it look like then from a policy framework. So that's legislative, that's policy. So I wanted to point those out. The other thing she said is she mentioned screening for first responders. So part of the pre-arrest diversion space, so done at the discretion, application à l'initiative des forces de l'ordre. So that this idea of discretion for police, we are beginning to tackle that in the United States. How much screening tools do we need to give the police in order to make good decisions, right? The research is clear when we make decisions on our own, we make really bad decisions. They're horrible, as a matter of fact. We don't do well because our brain can't process that much data. So what does it look like in the United States for pre-arrest diversion for officers to have a tool, ask some questions, and then figure out what should happen to someone? So that's coming in. And then finally, pre-arrest diversion, because I heard a lot of that today, is harm reduction, right? It's the reduction of harm. It's the idea of meeting people where they are and doing the very best that you can with them. If they haven't broken the law, all you do is let them go, so that might or might not be a good thing. And if they have broken the law, do we have a better option than putting them in jail or prison? That's what pre-arrest diversion is. It's harm reduction. It's harm reduction in a form that incorporates law enforcement systemically combined with treatment, systemically combined and grounded in the community. And what I mean by the context for America, the community, so it varies wildly. It might be a population that has a lot of problems with the police, a lot of disparity in terms of how they feel treated. That pre-arrest diversion effort might look different than one that's dealing with just kind of low-level crimes in the business district. So that's what I mean by that. So those are the things that I wanted to point out again in response to Dr. Gozlan's excellent presentation on Mildekar and what's going on there. The final two that you see up there, the one that I told Christoph, and he was so excited, he said, make sure you say that, is that mental health in the United States is not illegal. Drugs are still mostly illegal. So when we talk about pre-arrest diversion, we always make that distinction. It's not illegal to be mentally ill, but it is illegal to use drugs. But in the United States, if you call and you say, I'm having a heart attack, they send an ambulance. And even though mental illness isn't illegal, if you call and say, I'm having a mental health episode, there's someone's with a breakdown, they send the police. Isn't that weird? It's odd, right? So why send the police if it's not illegal? Because that's been our response so far, and pre-arrest diversion is trying to get to that. Okay. All right, so the word diversion, I know, Christoph, you guys are familiar with the word diversion from the justice system. The left-hand side of this slide is what pre-arrest diversion is about in the United States. The right-hand side is what diversion is about. Diversion is what you know as prosecutorial diversion, jail diversion, prison diversion, any kind of diversion where the justice system holds sway and has control over it. Pre-arrest diversion is different in that while the police are the decision makers because they see the person first, they hand them off to treatment right away, very quickly. Hours, maybe a day at most, because one, they can't do anything with the person, but two, we want to hand them off and get them into a behavioral health setting where they can receive the treatment they need, which might be housing, might be social services, might be mental health, might be substance use, might be a combination thereof, might be nothing. Some people do well just by leaving them alone, right? They actually do better. But the point is, pre-arrest diversion is behavior health driven, not justice driven. Everything we've done so far in the U.S. is driven by justice. That's in part why we have a lot of bad outcomes, because the tension between the justice and behavioral health system, as you know, is one that Who wins? The justice system wins, so therefore we do things like 3 strikes and you're out as a law. Commit 3 crimes, you go to jail for life. In the U.S., that's what I call policy made by the game of baseball. 3 strikes and you're out. So not good policy, even though it's a good game. Okay, in the U.S., there are 2 types. I actually wanted to pull this slide out, Christoph, but I'm going to do it anyway because you said hold it in. There are 2 types of pre-arrest diversion. The left-hand side, which is the majority of what's going on, is where police encounter folks. And again, remember I said they can arrest or let you go. The third way is they don't really divert you because there are no charges. The left-hand side, there are no criminal charges. The police would have just let you go. They realize that there's something more they need to do with Jack because Jack's exhibiting behavior that, while not criminal, I know I'm going to see him again either dead or I'm going to see him again with a future crime, and so they hand me off. That's called prevention diversion. I'm preventing future criminal activity, future death, or a future crime victim, right? The right-hand side is called intervention diversion. This is a small number of sites in the United States, whereas police encounter you, you have criminal charges. They could arrest you, but because it's a behavior health issue that is driving your criminality, and you haven't murdered someone, you haven't set the building on fire, nothing like that, pre-arrest diversion is allowing them the option to say, we're going to hand you off to a behavior health provider, and we're good with that. That is, and I come from law enforcement in the United States, that is a big, big change of culture for police. It is a big change of culture. So that's why there's much less of that going on. But there are 2 types, prevention and intervention. Okay, so here's what's going on. This is the big picture in the United States. This is when I said that this is a systems approach, right? It's a systems, 3 systems coming together. You see all 3 systems up here. The left-hand side, the justice system, treatment on the right, community, right? Everything is grounded in community. Even if it was prison, everybody's coming out, but this is not prison or jail, but it's grounded in community. And again, going back to what Dr. Gozlan said about the interministerial nature of how you have to do stuff in France. We have the same thing here, but done at the local level, right? In the United States, police chiefs in cities and villages make up a lot of their own decision. There is no federal guidance, and if they want it, they have to give money, and then the city's take it and they do it. But without money, no one does anything. So it's all really done at the local level for systems, villages, towns, whatever it might be. And what's happening in pre-arrest diversion is we're bridging the 2 worlds. You get that, right? The left-hand side has different values, norms, cultures. The right-hand side, and it's all grounded in the bottom, which is community. And so how do we bridge it? What's up here on the screen is what's called the task model. Christoph introduced me as being from TASK very quickly. The TASK model was developed in the United States and released in 1972. By President Richard Nixon before the War on Drugs declaration. Our veterans, Vietnam veterans, were returning with heroin addiction, and they were getting arrested, and when you get arrested, you go to jail. Back then in the U.S., people didn't want our veterans in jail, so they had to figure out a way to say, criminal justice, behavior health, you must figure out a way to come together, and this is what we call the bridge between the 2. So if you were to work in the U.S. system and you said, I want to do something between criminal justice and treatment, these are the 6 elements that you would do to connect. We have good research on this that says when we use these 6 elements on a repeated basis with fidelity to model, we get about twice the outcome, bang for buck proposition, than people who just go into the criminal justice system on their own. So twice is pretty good in the social science arena, right? I wouldn't want a doctor to give me a medicine that was only twice as good, but I'd sure want it for social service, right? Social science. So that's what we're doing. That's called the bridging system, the task model between criminal justice and behavior health. Okay, let's get into then what these things are called. I apologize for this slide. It's got a lot of words on there, too many words. Yeah, I know, that's exactly right, yeah. Too many words. So what I'm going to do, though, is focus. So these are the 5 ways in the United States when we look at what's going on around the country in which you can do pre-arrest diversion, right? What's in bold are the names that we have given those efforts, and what communities do is they start with one of these efforts, then they get some experience at it, and then they move on and they add another one, right? And then they add another one. To what Dr. Gozlan said, where you're seeing an increase in opiate overdoses and possibly death. The middle one, which is naloxone plus, English and French is the same, that's pre-arrest diversion uniquely designed to respond to overdoses. I don't have the elements of it, but it contains 11 elements that include naloxone plus, the carrying of naloxone, rapid integration on the scene of the overdose between behavioral health and police, immediate referral into treatment and detox, continuation on recovery and peers, and then naloxone again. But that's the one that, again, just Dr. Gozlan, from what you said, I want to highlight because that's the one that was designed specifically for overdoses. So these are the 5 pathways that exist for how we do it in the United States. We've not found anything that doesn't fit this yet. And while we're talking about addiction, the mental health side of it also fits in here also. We see mental health versions of this that go back quite a ways, actually, well before the substance use version. So these are the 5 pathways, and again, without reading it, the first one is the police say you can come into my station, and if you need treatment, I will connect you up. If you have drugs or drug paraphernalia, I will not arrest you. That's what the first one is. I can walk in to a station. The second one is the police say we know from our interdiction operations, our drug narcotics operations, who is possibly using. We call them. The police don't. They bring on a social worker and they say, hey, if you do need treatment, we're not going to arrest you. If you want to hang up, hang up. If you don't. And we give them treatment. So you can walk into the station. That's the first one. Second one, we can contact you. That's the second one. Third one is, unfortunately, you have to overdose. It's a pretty, bad way to get into a program, but you have to overdose. There's very early models of this using predictive analytics to begin to identify folks ahead of time through big data dumps. U.S. is big on data-driven justice and data solutions right now. And then the bottom 2 are what I said, officer prevention. That's police officers on patrol see behavior that they realize is not illegal. They investigate it, it's not illegal, and instead of driving away, they say, I know what you need, Jack. I'm going to refer you to treatment. And treatment might show up right away, or they might call you in an hour, or they might meet you at the station or meet you at their house. And the bottom one is just same thing, officers on patrol, but they have criminal charges. And again, instead of charging you, they move you off to behavioral health. Okay? So those are the 5 ways that we can do pre-arrest diversion in the United States. Next one here, and we're getting to the end. Back up one, there we go. So this might not have a lot of meaning. These are the names of some of the programs in the United States and how many sites. Main thing to take away from this slide, again, there's 5 different ways. These are different examples. Is that in the United States, there's 18,000 police departments and 800,000 police officers. If we include first responders, we're at about 1.2 million, which is fire and EMS, right? And so we can talk about this. The total number up here should be around 500. So we have about 500 police departments, a few more fire departments out of 18,000 that could do this. And so this is rapidly growing, but it's nowhere near scale. It's about 3%. But what we're seeing is the majority of these departments came on in the last 3 years. It is moving and growing extremely fast, right? Extremely fast. So that's the big takeaway. Again, if you visit the United States, we can take you to all these sites and lots of them and let you visit them. These are just some of the examples of the different ones that are going on in the United States. Okay? So why is this growing right now? And I know I'm getting on time. I said this would add a few minutes because I wanted to throw in the comments from Dr. Gozlan again, which are excellent. So why is this growing in the United States? These are the reasons that we have. I don't know the French context. Christophe did a great job, and Mike, with kind of prepping me. So I have some understanding of what's going on in France. But this is what it looks like in the United States for why this is growing right now. And it's safe to say that the opioid epidemic in and of itself, so number 3, is the main driver right now. The other 3 have been around. They're not new, unfortunately, right? They're not new. But the opioid epidemic is causing so many deaths across the United States. We will cross about 69,000 opiate overdose deaths. That's not overdose, that's deaths. We're at about 45,000 deaths a year from HIV, AIDS, handguns, firearms. Everybody in America's got a gun. That's at about 33,000. So it outstrips guns right now. It outstrips HIV, AIDS. And guns plus car deaths combined now still don't equal the number of opiate overdose deaths. And all the mathematical modeling is going up still. So that's it. Okay, let's keep going here because I want to make sure I went over a little bit on time and I can see that. I apologize. So main thing here, again, bad slide, too much on it, I get that. These are all the things we think pre-arrest diversion will help us do in the United States. You can take a look at those. Normally I'd ask you, well, which ones apply to you? Context is different. It's not a silver bullet, right? We're not selling it as the next best thing. It's not Samsung, the next big thing. What we're saying is that as part of a comprehensive system of treating folks with addiction and mental health issues systemically by using law enforcement, there's 800,000 police in the United States who encounter 68 million stops a year in the United States. 68 million people in the United States are stopped by 800,000. Only 12 million go to jail. That leaves 56 million people they encounter. Of those 56 million, some have addiction, some have mental health issues, some have both. These are some of the issues we think pre-arrest diversion, when it's scaled up in size, will help us deal with in the United States, in part or in whole. And the one that Dr. Gozlan spoke about, where it says the second up from the bottom, keeping families intact. In the United States, sadly, the men are gone usually. That means women and children. And so we put a gender focus on women in pre-arrest diversion to make sure that the extra supports and additional efforts that they need are there, because when they encounter police and get arrested or need to go in treatment, the kids are left alone. The guy's always gone, right? The men are always gone. They're off doing whatever. The women are left behind. That means the grandmother or the neighbors now have the kids, right? So that's how it is in the U.S., but I want to point that out. Okay, finally then, we're going to close up. In the United States, there is a national emerging movement, and it is put together around an organization called PTAC, which is the Police Treatment and Community Collaborative. Why PTAC? Because 40 people could not come to agreement on what letters and words should be used to name it. So at the end of about an 8-hour day, it was either me or I think somebody else said, we're just going to put these letters together and we'll get back to you in a week. And 2 of us did it on our own, and this is what we came up with. Is it good? I don't know, but it works. So PTAC is the collaborative national movement for the emergence of pre-arrest diversion in the United States. I'm just going to show you one more slide. We're going to skip that one. Here we go. This is our mission. This is our purpose, right? Everything in America is about mission. What do you do? Why do you do it? Mission, purpose, very important kind of our identity. We want to be able to move and act and get going on stuff. We don't want to do a lot of talking and thinking and stuff like that. I shouldn't say that, right? That sounds bad. We don't want to do a lot of thinking. But we want to act and we want to get going and we want to solve things. So this is our mission. This is our objective. It is about the entire national movement. And Christophe, don't worry. I know I'm a little over time. We're done. These are some of our founding partners. We have 26 national organizations and growing that have recognized in the last year alone the importance of pre-arrest diversion as the way for America to get at some of the many challenges that are facing people who are in recovery, people who have addiction issues. We don't use the word addict in America, by the way. We say substance use disorder. We do not use addict. So substance use disorder, who are in recovery, who have mental health issues, who otherwise would be in jail, on the street, or just dead, right? That's the reality. Their health declines and eventually they die. I'm going to point out one on here. Let's see if this works. This is the logo or the symbol of the International Association of Chiefs of Police. We in America name everything international. If it's at least in America, we call everything international, right? They have a few offices in other countries too. They represent all the police chiefs in the United States. They're a major player in this, and absent them being part of this, to use English vernacular, this ain't happening in the United States. So it's a big deal that you see their logo on there, because they have signed on and said, yes, for our law enforcement community in the United States, we absolutely see the value and the need for our officers to be doing this kind of work. So with that, and again, I know I ran over time. I apologize to my panelists. Again, anything that goes wrong, that's Christophe's fault. Anything you like is my good work. So I'm going to leave it at that. But thank you very much. I appreciate the time, and I look forward to the discussion and hearing from others. Thank you.
Thank you, Jack. We're going to continue with Mike Trace, and then we'll be able to go into the questions and answers.
Thank you, Christophe. Thank you, Jack. And also apologies from me. I'm the second speaker here who is not even further from being capable to present to you in French, so I will be presenting in English. So good afternoon, ladies and gentlemen. Thank you to iCAAD and Christophe for this invitation. Jack has laid out for you there many of the principles of pre-trial diversion and talked about a lot of the things that, from a UK perspective, we have grappled with for many years. I've been asked to give an example, if you like, of those principles. Some of you may know that in the UK we've had a drug policy around diversion from the criminal justice system for at least 20 years now. And we have tried to implement some of the principles Jack talks about, and we have a very uniquely British lesson from that. As Jack said earlier, I'm not here to tell you it's a solution to anything or a blueprint that should be implemented in France, but looking back over those 20 years, we have learnt quite a few things about what works and what doesn't work in diverting drug offenders away from the criminal justice system and into healthcare systems. Our system in the UK, we have had a diversion policy that isn't only about pre-trial diversion. It's not just about a police and community process. It also is focused on what happens at prosecution and in the courts. In fact, the early diversion schemes we had in the UK were court diversion. So even by the time people had considered what sort of addiction treatment they may need, they had gone through quite a lot of criminal justice process by the time that issue was considered. I'm going to focus on the criminal justice system for these comments, but something that's very much a lesson from the UK and very relevant to your earlier speeches this morning is the question of diversion to what? We found that wherever we are successful in helping people to be diverted away from criminal justice and not returning to offending and courts and prisons is where there is good quality treatment to divert them to. So we have many experiences of poor results of diversion, and that usually is associated with poor quality treatment, and we have some very exciting results where the treatment is good quality. So the presentations you heard this morning about the importance of quality and effectiveness of treatment is very relevant here. A bit of context to what I'm going to say to you. First of all, the policy context. As I said, 20 years ago I was the UK drug czar in the Blair government. Now, asking you to cast your mind back 20 years tells you how long ago it was we had a Blair government in the UK and how old I am. So this all happened, this policy really took off in the late 1990s. In the late 1990s, for our government at that time, drug policy was a priority, which it's not now. The current UK government thoroughly disinterested in drug users and drug policy. But in the late 1990s, it was one of the top government priorities. And we were fortunate enough at the time to have lots of money in government. Those seem a long time ago now, but we were a government with money to spend. And we had a government that was interested in social policy, in social justice. And that allowed us to have a treatment focus in our drug policy. So the strategy we had, the government-wide strategy in the late 1990s, and for many years after that, the priority was treatment. As Ruth has described in terms of Mildeka, of course that is within a context of there's some repression in there, there's prevention, there is public health measures, education measures, but for us in the late 1990s, the priority for our money was to expand our treatment system and improve the effectiveness of that treatment. And the purpose of that, and this is why the criminal justice system has been such a focus for us, is one of the reasons and objectives we wanted from the treatment system was to reduce crime. Through the 1990s in the UK, we had a big correlation between street crime, low-level offences, thefts, frauds, and low-level violent offences, and the drug market. So we had a lot of community concern around street crime, and that was understood, and research showed it to be the case. It was very closely correlated with the drug market, particularly for heroin and cocaine in those years. So that was the context in which we felt we wanted to concentrate on diversion as a policy. The other context was the research we were doing at the time, and I think this is very relevant to France today and many other countries, certainly in the US. The research we had at the time, like in many countries, we researched what the scale of drug use in our society was. And we had pretty good data through the 90s that we had around 3 million adult users of illegal drugs, regularly using. So not daily use, but those were people who were reporting use in the last year or in the last month. And 90% of those, there was no evidence that there was any other criminal problem apart from the fact that they were drug users. They were not committing these crimes, they were not prolific criminals, they were not dealers. So 90% of the 3 million people that up until then we had said our policy was to try to catch and process through the criminal justice system had no other problem in their own drug use, and they were causing no other problem to society. Now, quite apart from anything else, the accountants amongst us were saying, well, we're spending an awful lot of money on 90% of people who are causing no other problem to society, and they are filling up our court systems, filling up our sometimes our prisons, and these are not our priority cases. So we were saying of the remaining 10%, the 300,000 individuals, there was a problem. There was offending, there was social dysfunction, and there was addiction. So these were the people that we wanted to respond to by offering treatment and offering help. So the first challenge was to work out the difference between the 90% and the 10%, which is easier said than done. But basically our policy was to focus on the most high harm group. And as I say, this group were, as you could expect, were highly correlated with the people we found in the police stations and the courts. And we had gone through the 90s, and I'm sure you did as well, as trying to say we want to reach out to people who are taking risks around HIV and around injecting. We wanted to reach out with people whose lifestyles were outside the mainstream. And our outreach was mainly situational. We had lots of workers who would go out, hang around on street corners, try to engage with a very marginalized population. And over the years, we found that it was much more efficient to meet them in the police stations. That's where you would find them. So how did we engage in that diversion? We had basically 3 stages. You saw in Jack's slide where there is the left to right, the criminal justice process, from police through prosecution to court to prison. We tried to implement diversion, and to use an American term, we tried to provide off-ramps. Like if you're going along a motorway and you drive off on the off-ramps, we tried to provide an off-ramp at each stage. And the most comprehensive thing we did is what we called arrest referral. At its peak, maybe this was around 2002, 2003, we had a drug advice worker, a diversion worker in every police station in the country. The quality of this, the availability of the staff was never perfect, but we did have every police station in our country. If somebody was arrested, not the arresting officer, not the police themselves, but a social worker would be available to speak to somebody and say, is the reason why you are now in this police station, is it related to drugs or alcohol use? Is that the reason why you're here? And if you are here, I can talk to you about access to treatment. And that conversation would not be linked to the charging decision. You can imagine the problems that would come up if it was the charging officer making the same conversation. So we had arrest referral. That was our first off-ramp. And it's something we were very proud of. It's not as widespread now as it was 10 years ago, but we did create social workers in every police station. Then we had probation referral. I'm not sure what the equivalent is in France, but the social workers attached to the court would conduct the same process and same service in the court. So if somebody was appearing in court, maybe for a bail hearing or for a report related to their offence, then they would have a probation officer in the court who would advise them and talk to them about the circumstances around their offence. So what we had in our diversion system was the probation officers were given the mandate and given the resources to be able to talk to people about their treatment needs and refer people into the treatment services. And similarly, on the third off-ramp, we had court-ordered treatment, which in America you would probably refer to as drug courts, and where somebody is sentenced after their offence is heard, and the sentence is to attend treatment rather than go to prison. So we had those options as well in the UK system. Now that was what we called a comprehensive system. It was a well-resourced system, it was a well-funded system. Remember, we had money 20 years ago, and we created it as a national program. And we, as I say, we had arrest referral social workers in every police station, in every court, and we had thousands, tens of thousands of people going through the criminal justice system in the UK who were offered the opportunity of treatment. That's the good news. We created a national system. And I'd like to say there were some successes of that policy. We look back on it now, 15 years later, and we look back on it as a successful policy. We now have, and we still have in the UK, what we call a high penetration rate of our treatment system in the UK. So that's not just because of our criminal justice diversion policy. We have also invested very heavily central government funds into expanding our treatment system. So we have a big system. It was well funded. It's having its funds reduced now, but it was well funded in its time. But we have developed through those years a very high penetration rate. As I say, we think we have 300,000 people who are the target group, who are have problem drug use disorders, and we think around 210,000 of those are in touch with treatment. So we still have a gap, but the gap is not as big as we understand is in most countries. And at the height of our treatment expansion system, we think we reached around 70% of all the people who were struggling with drugs problems were in touch with some sort of treatment service. Now the downside of that, which I'm going to mention in a moment, is the quality of those treatment services vary very widely. So that contact with treatment services does not mean that that individual is getting what would be the considered the high quality treatment. But we have had, over those 15 years, the research we've done into the diversion policy is it has had a major impact on reducing crime in the UK. Now, in the UK, our crime trends, our overall crime trends, are not that massively different to other Western European countries. There's been a general reducing trend over the last 15 years, but we have reasonably good research in the UK that one of the reasons for this reducing trend is that a large number of people who were quite prolific offenders before going into treatment, after treatment, their rates of crime came down quite significantly. And that did have a national impact. That's not, obviously the personal impacts, the human impacts of that treatment are very important, but at a society level, we had a reduction in the overall crime rates related to our drug markets. We also, I think like France, we have managed to maintain through that period a high level of engagement and delivery of healthcare to drug users, and that has meant that we've been able to keep on top of the public health challenges. We've always had relatively low HIV relation to injecting drug use in the UK. We've managed to maintain that position, and we've managed to have, as I say, a large number of people with drug use disorders receiving general health care, receiving HIV prevention, hepatitis prevention. But, and this is a very big but, and it's confusing us, with this expanded system, with this high level of engagement, we have a massive overdose problem in the UK. In European context, it's not, we don't have the figures as scary as the US are having now, but we are clearly the country in Europe that has the highest overdose rates and the highest death rates related to acute poisoned reaction, what we normally call overdoses. In the UK, the figures have not gone down. If anything, they are going up again. So we are not quite sure, with all of this work we've done to get our target population, to get the best healthcare, get into the best recovery systems, we still have a very big problem with overdoses. So if anybody has any other questions, or preferably an answer to that, I would very much like to hear it. So we look back on this as a good policy, looking back over 20 years. As I say, it hasn't solved fundamentally changed the nature of the drug problem in the UK, but we generally see we've had good individual and social outcomes from this. The big lesson we take from it is the variable implementation. And as I said earlier, one big lesson from that is just congratulating ourselves that we have seen somebody in a police station and sent them to some treatment, any old treatment they're in contact with. We have found that the quality of the treatment, the diversion to what, is massively important. Areas that have provided good treatment get great results. Areas that provide low quality treatment get bad results. And as I mentioned earlier, our big problem the last 5 years is the loss of focus. We've built up a good architecture in the UK, a good national system, and because of the lack of political attention and because of the reductions in funding, I don't know if you're experiencing this in France at the moment, we've had very significant reductions in investment in social care generally, but in addiction treatment particularly in the last 5 years. And so the system is crumbling as we speak, the treatment system and the diversion system. So it's not all good news, and as Jack says, I certainly would not commend to say UK has got this right, you should try what we do, but we have had a broad experience with what is generally a good policy, which is get your people, drug users, out of the criminal justice system, get them into the behavioural health care system. You will get much better results. Thank you for your time.
Thank you very much, Mike and Jack. Before I leave the floor to you in the room, I'd like to maybe broach a couple of ideas or questions very simply. Dr. Gozlan, you talked about the psychosocial, psychotherapeutic approach, whatever you want to call it, and I've heard of functioning models in the US, models that are being implemented right now, models that have been implemented in the past in the UK. I'd like to know whether we do have the means to implement a policy of diversion currently in France. When you think about the system, like, could we really have a system that really works on decriminalization and diversion? Could we, because the volumes are very high, so can we face the volumes? Because if we decide to have a policy set up, then we'll have to answer those people, we'll have to answer their needs to satisfy their demands. Well, theoretically, if we started working on decriminalization, we could imagine that the number of users would remain more or less the same, which is what you can see in the US, especially if the system is properly regulated. And we would therefore save a lot of money in the police departments, in the justice departments. So we would probably be able to satisfy the needs of that population. But it's not only that population. We heard during the presentations, we talked about illicit drugs only. We didn't hear anything about alcohol. Alcohol is responsible for at least as many crimes and as much criminality as illicit drugs, even though it is not forbidden. And so we don't really have the means to respond or to react properly to violence or alcohol-induced violence or disorders. And the question of managing patients who use other substances, including heroin or cocaine, I mean, I'm sure Jeanpierre will have a lot to say on that issue, but it is still not sufficient. We still need to do more in that respect. We also have set up very, very late in the game, really, substitution treatments like methadone and ibuprofen as well, with results that are overall rather good in terms of behavioral, the behavioral aspects, in terms of the users' lifestyles. And we're expecting the wave of opiates coming from the US. We do have a feeling that things are, there's an upwards trend in France as well, but I do not know whether maybe France has been spared so far, because the prescription rules are not the same. Thank you, Jeanpierre. From the point of view of training and the possibility to have more psychotherapeutic aid, yeah, well, I'd like to come back to what Michel just said. There's always something in there, as far as I'm concerned, there's always the unsolved question that was mentioned by Mike as well at the end of his presentation. It's not just about, like, somebody who's considered an addict, whatever the product, can meet someone who's considered as a carer. You have to make sure that if they meet someone, if they meet a healthcare professional, that has to lead somewhere, that has to have an impact. And sometimes it's complicated. We just have A meet B, but we don't really make sure that something happens after that. And I think, it's all well and good to pair people with other people, but it's not really meeting at that point. It's just having someone see someone else. And I think over the past few years, we have a lot of people here around the table. We tried to think about our professional practice, to check whether they were really adapted, what we could do better, and how we could, little by little, make sure that our practices could continue improving. And when we come back to what Michel was saying, we tried, obviously, we tried to work with the police, for example. We tried to use that gateway that the legal system can be. I mean, of course, it's not perfect, but at least it's a red flag. You have the possibility to detect, to screen those people. But we know also that when you get arrested in France, you can't think about police and arrestation without thinking what the situation is like in neighborhoods right now. Sometimes with the economic crisis, the relationship between the police and the population has gotten very dire. I worked in a very rich police department, in a very rich department in the west of Paris. We know that we always have the arrests for cannabis use in the same cities, and it's not always the same population for cocaine or for heroin or for cannabis, and the relationship with the police is not always the same either. So you have to think about all this as well in a very complex manner. From the perspective of healthcare professionals, I think there's a race, for first responders, the first level. We all dream of a fantastic world where any GP, any chemist, any even a dentist, right now, sometimes we try to mobilize dentists as well. We would like for everyone to be passionate about addiction. But when we speak to them, a lot of them tell you nicely, okay, well, I'm a general practitioner. I'm not an addictologist. I'm a dentist. I'm not an addictologist. I'm not interested in all that. So we tend to, we're always faced with that contradiction. How can we make sure that people are interested in something that they are not really interested in instinctively, so to speak? How can we make sure that it works? And the third point is, I was listening before to the expert patients. I was listening to the great work that has been reported so far. We try to, of course, answer. We talked about risk reduction as well, which is very important. And for a lot of those people who are in addiction situations, I think the problem is the quality of the care that is provided to them. Very often they have had too many contacts rather than not enough, and too many contacts that were pointless in the end and futile. And I think I talked to a lot of colleagues coming in from other countries with other tools, and they were wondering, whether we're using the right tools, whether all the tools were available to everyone. So I think we should diversify the care solutions. It's important in France to accept that the one could do it, but not the other. If everybody wants to do everything, we won't be able to fund it. So it's important to say, like, this stakeholder will have beds, this one will have a daycare center, this one will have just a mobile unit, for example. It's important not to have redundancies, not too many in any case, because otherwise the ministries will tell us, well, you're all asking for the same thing. I'm not going to fund the same program 3 times. But I think very often there's not enough connection. We work in silos too much, and we don't have the right offer in place. So to finish on that note, I think we have tools. It's not all bad. Definitely, but the results are catastrophic because we don't have the right gateways, the diversity is not sufficient, and the organization, when you manage to get a connection with the healthcare system, it doesn't always work. It doesn't always lead to anything. There's a word that we haven't talked about so far, and that's the word training. Is there a reason to that? At the Mildeca, I heard that we needed to have people who are more performant on some specific points. Is there a reason why you didn't talk about training anymore? Not really, no. It's just I chose to focus on other things today. Training is very important. It was already very important for the previous government plan. We worked on initial training. In terms of healthcare, we worked on introducing more training. We try to make more room for addiction. What we noticed is that the question, it's not just about training. It's important to train, but I think in France we have worked very hard on improving the training sessions. But it's not just that. You also need to have training provided not only for healthcare professionals, but for other stakeholders as well. And when you have best practices guides, when you have guidelines, when you have guidelines in every possible field, how is it that in addictology you can't make sure that those guidelines are really, that professionals really buy into those guidelines or take ownership of them? So we'll continue defending addictology in terms of initial training. We'll keep working on continuous training, lifelong training for GPs, for dentists, for nurses, for everyone, for specialized professionals as well, so as to make sure that everybody is aware of new addictions or addiction to screens, for example. But it's very important to provide more efforts in terms of making sure that healthcare professionals take ownership of those programs, of the guidelines. It's all well and good to publish studies and to make surveys and so on and so forth. It won't change anything if people don't take ownership of them, don't use them. And this is really what we'd like to focus on. Thank you. Did you want to add something? Well, as we say in the US, I have a dream, and one day you could imagine that all healthcare professionals, regardless of what specific field they work on, would consider it the basis to deal with addiction problems, whatever they may be, at their own level. And if they can't do that, maybe it's important that they know how to divert people, where to refer them to. So addiction must be considered exactly as any other pathology. We tried to develop different approaches. All of us tried. Everybody always says that it's not going fast enough, it's not going far enough, and it's absolutely true. We've increased the number of trainings, but it's still not enough, especially in the medical world. And doctors, general practitioners, first responders, ER workers, they are not competent. Not always, and they do not always consider that it's their role to do that. Some of them do it really well, but overall, I think for psychiatry as well, for psychiatrists, we did insist on that so much that now more or less that they've accepted that addiction is an integral part of what they do. But we've talked about addiction, we've talked about people who were outside the system. And we still have healthcare professionals who do not really believe that they are concerned in any way. Overall, I think the basic network is not satisfactory. It doesn't mean that what Jeanpierre and Ruth isn't true. We still need to integrate best practices, and it is true that addictology, is not the same as orthopedics or diabetology. There's an personal dimension, there's a dimension that is very specific, and you can't have protocols like you have in oncology, for example. So, however, in spite of that, I think we have a good possibility to improve the situation.
It's difficult, the situation sometimes complicated, sometimes violent, with connections with justice. if you start something voluntarily, but then at some point it becomes involuntary, that's difficult. But I don't see why we wouldn't manage to. Others have done it before us. Chris, you wanted to say something? Mike, sorry.
On what Jeanpierre Couteron said about making contacts becomes a fetish and in the criminal justice system or elsewhere, but what happens next to actually affect the person's life. And that's something I think was very important lesson from our experiences. We became very good at making contacts, many of which didn't go anywhere. And the lived experience of the individual there, who maybe for the first time has trusted authority to say, I need help, I want to talk about my problems, found out it didn't go anywhere. And that's the worst of all outcomes. So yeah, I think that's very important to remember that. Fetishizing making the contact to what? What's difficult institutionally, even if you have a big budget, is yes, contact to good quality structured treatment. We would all, I think, support that. So getting into a good abstinence-based program, getting into a good maintenance program, with all of the human processes that help around that. But of course, institutionally, that in a perfect world with tens of thousands of people, the reality is people don't get immediate access to that every time the day after they've arrived at the police station. Something that's very encouraging, I'd like to ask if this is happening in France as well. An encouraging trend in the last few years in the UK is the development of what we call recovery communities or recovery networks, which are the gatherings or the networks of people with lived experience who are not institutional, they're not paid for services, they are just a network of people you can put an individual in contact with so that they can see lived experience of recovery, they can see positive role models. Now, that to us seems to be a very positive addition to our treatment system, that even if you can't get somebody into the structured treatment, they are in contact with positive influences.
Thank you, Mike. Merci beaucoup, Mike.
I don't necessarily want to insist, Vincent. I would like to hear your point of view. Vincent Fiat is just here. Once again, I'd like to hear your point of view. The DVO is an association on the field. Jean-Paul is a former policeman. He's not here today, but you work with him. I would like to hear the voice from the field. The field, or I should say the pavement. So I feel I'm a bit skeptical about the possibilities that we have in France, especially, and I see what's done in the UK and the USA, and I wonder why we have so few therapeutic communities when they exist in the USA and Canada, Portugal, and the UK. What's going wrong here? What's the blocking point here? This is a shame because it's a system that works some people, as we heard this morning, for the therapy community in Aubervilliers and another structure in the same model, EDVO in the Paris region. And I'm not really good with figures, but I think there are 4 or 5 of them in France. So I think we're losing out there. It's a model that doesn't work for everyone, but it's a model that can work for certain people. And the DVO has been around since 1987, so it's been 30 years. A lot of people have been through the doors, and it's been working well, even if it's been around 30 years. So I wonder what's going on. Why can't we do it here? Why are we not lucky enough to have these communities with a model based on peer groups, support groups? Why can't we implement the model that exists in other countries? That's what I'm thinking. Thank you, Vincent. That's also what I'm thinking. That's what also what I'm wondering. Who could answer this question? First of all, there are therapeutic communities in France. There are not 4 or 5. There are 11 with residents. There are as many as the historical French therapeutic centres. That's 350 places. I think that the issue is not. I understand that you're defending what you believe is the right approach, but in terms of public policy, what's important for us is that addiction is not an easy problem to resolve. What's important is to have an encounter, to have the right therapeutic approach for the right person at the right time. They need to have a palette, a range of care solutions, treatment solutions. There are people that get out of addiction on their own, but there is risk reduction and abstinence. There are solutions that can be offered by the authorities. And what we've done in France is to not oppose these methods, and we want all healthcare professionals to understand what we want is to have a range of solutions and to have integrative solutions, meaning when you're a clinical therapist, that you can send someone to Narcotics Anonymous when they need it. You can send them to a psychiatrist when it's the right time, where they're asking for help, but it's relevant, whereas it wasn't the right time a few years before. You could refer them to a residential structure when they need it. We have residential centres, long-stay centres with therapeutic communities, but what's important in terms of public policy, to have that in public policy, and that's what we try to develop with an extension of the range of solutions. And the therapeutic communities do exist in France. It's not been easy. There has been opposition to this approach, and I think we've got beyond that. But as Jeanpierre was saying earlier, everyone's defending their own point of view. But we're not in public policy. We're not here to defend our interests, but the public interest, and that the public interest is to have a wide range of solutions. I would also like to add to this, because it might be to have a discussion on this, and trying to answer other aspects of the question. When I arrived in this sector, for me, the therapeutic community had a very bad reputation. As a young professional out of a psychology university, I think there must be medical approaches, social approaches, therapeutic approaches, and in this transdisciplinarity, which is not the same as multidisciplinary, we need to. When I arrived in the sector, I had a clinical expertise and a very bad perception of therapeutic communities, which had the reputation of the patriarch, which hadn't given good results for everyone. So we needed time to get rid of this image, and we needed to meet new people who gave us a better image of the therapeutic community, and that takes time. However, we need to present this. I'm still the president of the Federation for a while, so I still need to be prudent, but then I'll be able to go wild. I mean, not wild completely, but when we talk about therapeutic communities, there are some people say, some studies say that it's not effective. So we need to take these into considerations. There's a second stage. Michel, you took part in a commission on addiction where good opinions were given on therapeutic communities, but it took time. It took a while for the commission to give a favourable position on therapeutic communities. Then it takes time to implement them. It's maybe not enough. It's maybe not sufficient. But the problem is that we're faced with residential care has a bad image because it's expensive, some might say. But hospitals need to also have mobile units. It's outpatients. There's a lot of pressure to have outpatient procedures, and so residential therapeutics has a bad reputation. We're starting to hear there's not enough voluntary workers in France. So just to conclude is that there is this sort of. There was a time where there was an opposition to the definition of the utility of this method. Now we've got past this, but now there's another issue we're confronted with. Just at a time that, on the whole, residential care has a bad reputation. I am convinced this is unfortunate. It's a mistake. I've written text on this. I think it's a false saving. Because some people need it and they go through other treatments that are not effective for them, and for the ideal solution you need to work on any ideal solution. It's not done overnight. So the ideal solution is to improve reorientation, to decide when is the right time for them, when it's not the right time for them, and that's where the encounters on this aspect of treatment, at least until we find a hidden treasure in the government's funds. Thank you, Jeanpierre. Just did you have another question, or did they answer your question? No, it's not really a question. It was to tell to our Anglo-Saxon friends about. Can we keep that for later? I would like to. There's a very important theme on the applicability of care. We can see in the USA and UK there has been a lot of residence care, and they're trying to backtrack with case management with very bespoke solutions, optimized solutions, like a la carte solutions, if you like. And I'm talking about an American system. Do you know what rehab? There are $37 billion goes into rehab centers. $35 billion, sorry. And there are patriarchs working in them. There's for our friends here, the patriarch here is a con man. We're looking at the two approaches. Radicality is not effective. It's very expensive, either in terms of coffins or inadequate or inappropriate care. But I'm coming back to Michel. The advantage of his experience is that we've seen a certain number of things for which people were enthusiastic. We saw, in terms of addiction treatment, replacement therapy, that some of us were very enthusiastic about for 10 years, and now, and it took 10 years for them to be accepted. We saw controversies on the duration of hospitalization. Jeanpierre talked about the issue of the patriarch. Self-help groups like AA and NA were fairly far away from the medical system, and they were working in their own bubble, without there being discussion with the medical system, and not necessarily a very good mutual reputation. So we need a certain time to accept that there is not a single solution. So it's more important for a medical protocol is right, but we don't know what treatment is best for what patient straight away. But in most cases, you need emotional support over a long period, whether this is done in a residential care or mobile units, for the patients to be able to stand as being in mobile units or residential units or post-cure units. 20 years ago, these units were in the middle of nowhere, and there was no monitoring afterwards, and there was quite a lot of relapse. That is a not effective system, and now we have over-medicated, so psychiatry has closed the number of beds, and now as a result a lot of these former psychiatry peasants are in prison or on the street. So we we mustn't go into case management and leave people on the side of the road. It goes back to an issue of competence and skill and decision making, doesn't it, Michel? In a very sensitive subject, because we're not really sure what we're talking about. Unfortunately, this model is very vast. It doesn't it doesn't cover the whole solution. He's referring to a pathology, but I missed the reference. There's a consensus on it being a pathology, but it's a very complex one. Rani, and then I'll come back to you. Thank you for your presentations. I think what we're missing in France also is a connection between the different structures and the different centres, and that people go repeatedly to different centres, hospitals, residential care, and then they come out. And I think there may be as a stage, which is not residential, but maybe daycare centres, day centres where people could go just for the day, and there'll be maybe a connection between the different levels of care, where they could have dates on the different treatments and how to manage their treatment. People don't necessarily know what kind of treatment they're having, so I think there needs to be a halfway solution between the existing solutions, which could be very interesting to allow people to continue their treatment, and even if they go they're leaving residential centres and they need to continue support, but not in an individual basis with a psychiatrist or with a weekly meeting, but another type of support. Thank you, Rani. There are certain types of institutions like that in the London area for the reasons you described. I'm going to give you the opportunity to ask a question, because we're going to talk about criminal issues as well. So to encourage our Anglo-Saxon friends, I want to tell you that I'm a clinical psychologist, and I just so happen to be on the list of courts, meaning that I can be sent people. In France, what happens is that I get a call from someone who tells me I need to meet an addiction specialist or someone specialist in that field. So the person comes before going to the court, and he has 15 days to fill in the form. And on the form it's written, I, the undersigned, declare that I receive the following person, and I just need to stamp it, and I refuse to sign the form on the first sheet. Even if I say I'm not going to sign it on the first time, you have to come back. After the second meeting, there's no connection. I'm just parachuted into the system. So at some point, I just stop doing it because it's a disastrous situation. The people from the courts never met me. They never asked to see me. Even if I tell these patients who don't have any money, even if I reduce my rates because I'm committed to the project, even if substance abusers and alcoholics are there, there's a sword of Damocles over my head. The dates that they need to sign the form and show it to the courts, and then they disappear into the wild. And I find this situation catastrophic in terms of connection. Secondly, so the other thing that interested me today is the question about the direct question, asking someone directly, do you take drugs? I have the impression that, this is just my impression, I want to share with you, see if you feel the same way. It's like it's a taboo question, as if the doctor who asked the question would make the patient feel, as if the doctor would feel guilty about drinking a few glasses of wine with his friends. patients don't talk about it, doctors don't talk about it. So I think this is a taboo subject, and I'll keep my third question for next year. Jack, do you want to answer the question?
Good, thank you. It's a very good question. So in the U.S., to respond to the problem that you are describing of, and I love the way you said it, being parachuted in. Well, wait. Okay, there you go. Since you got your headphones on, I'll start over very quickly. To respond to the problem you describe of being parachuted in, many of you are probably familiar in the United States. We started the development of drug courts. And in the United States criminal justice system, if you hit the courts and you have a clinically diagnosed issue with drugs, if there's enough of them, you will get into drug courts. And drug courts are based on a systems approach. A lot of the work we do is systemic in nature, which requires a team to continuously check in with each other to avoid exactly what you're saying. The challenges in the U.S., there's only about 2 to 3% penetration in the court system of drug courts. So the vast majority of people are still hitting what we call general jurisdiction courts. They handle all the other cases of people who don't go to drug courts who also have addiction, and that experience might not be that uncommon in the U.S. Maybe not that kind of far out there because we do a lot of systems work in the U.S., but the drug courts have been our response to the disconnected relationship between courts, prosecutors, treatment, the individual, their job, their family, and in that we have very good research on outcomes. I'm not saying France should start drug courts, but the ability of the integration to be there absent is exactly what you described. And so that's been kind of one of our approaches to it, is to say, okay, with the most severe, clinically assessed at the highest level of addiction, we will put them in these specialty courts. The problem is you have to get into the justice system to access that, and that's, you have to commit a big crime to get in there. So until you do that, you can't get access to it. So.
Merci, Jack. On a encore quelques minutes, mais pas beaucoup plus.
We still have a couple of minutes, not many more. Does anybody have a question? David, we'll give you a microphone. Don't move. Thanks. I wanted to come back to what the professor said before regarding alcohol. And I believe there's an epidemic in France that we don't talk about. I'm speaking of benzodiazepam. And I wasn't here this morning very early, so I missed some of the presentations. But I think we have a lot of issues with alcohol in France. There's a real epidemic at all levels of society, especially when mixed with benzodiazepines, and we don't really talk about that so much. I think we have a lot to do in that area. We do not have the same wave of opiate issues that the US may have, but we do have some specific problems in our own country, and I was a bit surprised and worried to find out that a member of the government declared that the alcohol molecule in wine was not quite as noxious as the alcohol molecule in other sorts of alcohol. I fall off my chair. It's only in France would you hear something like that in the mouth of a member of government. Yeah, apparently the classification of elements is no longer valid in France. I understand your point, David. Dr. Gozlan, benzo, do you have anything to say about that? Well, those are very good drugs when they are prescribed well, and depending on the recommendations as well. There's a real question with regards to the drugs themselves. We asked for a general survey and expertise from the INSERM to do with the management of psychotropic drugs. I actually read that again recently, a couple of days ago, because I had to write down the government plan. There's a lot to be done with regards to those drugs, but or to this type of medication. There's a lot to be done for alcohol, for benzodiazepine, for a lot of addictive behavior. The idea is to work on prevention, to work on making sure that everybody is aware of the problem so that we can get a handle on it. In public policy, we'll have a lot done around medication. I know that young people died recently because they had been mixing psychoactive products with, or rather several drugs. They died of poisoning because of mixing too many drugs. So that's definitely something that we need to have a look at. I have a patient who's 18. He stole his dad's credit card and ordered 3,500 volumes over the internet in Russia and started selling them. It didn't really work because he took half of them and ended up in the hospital with an overdose. Yeah, you could order ecstasy pills at home benzodiazepine is not really the question. The question is access, and the fact that it's not always possible to control access. Yeah, you're asking. I mean, this is a question about accessibility of drugs over the internet. It doesn't really have anything to do. I think that's what David was referring to. The question of access to those drugs, even though the possibility to buy those drugs very easily. Yeah, I don't know. I'm not sure that's what he was referring to. Some people worry that doctors prescribe it too much or don't prescribe it well. That's also a question. But we've had that report that was done by the INSERM. Some countries have alcohol very... there's a lot of control over alcohol, and they use a lot more benzodiazepine than in France. So you have some transfers with patients using one product instead of another. And that can make the situation very complicated. If you prohibit one product, the patient may turn to another. And so it's very important to work upstream, ahead of that, before the problem occurs. How can we help people either follow the doctor's prescription, or how can we make sure they don't need to order 3,500 volumes over the internet? Yeah, it's not a very popular thing to say, I know, but I think it's important to mention that when you think about addiction, you need to think about lifestyle. Why do people use those products? Why? Unless you start thinking about that, you're going to be walking in a circle. I mean, at some point, I think we'll say education is key. Being interested in human beings is key. This is where we need to start. Thank you, Jeanpierre. Yeah, just a word. From what I understand, we've been asking ourselves, or they have been asking themselves, in some states in the US, they noticed that in states where cannabis has been legalized, alcohol consumption has gone down. So it seems like cannabis seems to replace alcohol consumption. Yeah, I think we have the same... we have surveys from the UK as well. Yeah, I think it's a very important point in the discussion, actually. With the opiates crisis in the US, I think there are very often ODs or severe respiratory failure that are linked to the use of opioids and benzodiazepine. And I think in this situation, it's very difficult for users to manage this, and it leads to a lot of deaths as well. Right now we can see an evolution in a lot of countries, or in a specific category of psychotropic drugs like cannabis in Canada, in a lot of American states as well as in South America and in Europe too. We've had very different levels of legislations. Our British friends, have you thought about the relationship between justice on the one hand, and the police system on the one hand, and the healthcare system, trying to optimize a person's pathway? I mean, the evolution of that context of criminalization, the question of management, of care, within the framework of potential deep prohibition, would that maybe be able to change the deal? Would it maybe solve some problems or make some problems worse? Or, I agree with what Jeanpierre has been saying. We're still thinking within the old framework. Our government has not decided to decriminalize cannabis, but I think it's important to think about the system as a whole. There have been some legal evolutions, some legal changes, even by major stakeholders like the US, not federally, but at the level of the different states. They played a huge role in terms of legalization and agreements and so on and so forth. Has that changed the pathway for addicts? And I mean, behind that question, there's another one. How can you invent a new way of caring for people within a framework where prohibition no longer exists, or to some extent? Mike, would you like to answer that question?
Thank you for that question at 22:07.
Ce sera la dernière. It will be the last one.
But I would try to say a couple of points because I agree with the direction of the question. In my speech in the UK, we decided to use the criminal justice system to get access to people, and we thought maybe that was a good way of encouraging people to accept treatment. I think we took a bit of a wrong turn there because it is totally not ideal to try to build up a therapeutic trust and a therapeutic relationship with somebody who has the fear of the criminal justice system. So I wouldn't advocate that as the perfect solution. But we work with what we've got. In terms of whether that suddenly becomes much better if we remove the criminal penalties, I think the basic realities, I think it was mentioned earlier, will remain. There is the problem in society of people who have the feeling they have to self-medicate, and they may use alcohol, a legal drug, they may use a prescribed drug, they may use an illegal drug. The problems that they face and the help they need to get past those problems will exist in any criminal justice structure. But we don't help ourselves by treating a proportion of those people as different and other and in need of punishment. So the tenor of your question I agree with, but we work with the systems we have.
Merci Mike. Michel, Jeanpierre, Jacques, une dernière phrase avant de conclure.
Michel, Jean-Pierre, Jacques, maybe a last sentence before we conclude. Yeah, well, see you next year. You know, it's very interesting to learn from one another, to try and find out more about our experiences. I think maybe at some point it'll be useful. Jean-Pierre, next year I don't know, because personally I will no longer be the president of the Addiction Federation. It's a relief as far as I'm concerned, but I think it's really important to try and create complementarity, to enjoy our diversity and to learn from one another. I think that'll already be a great progress. Jack? Yes, I know, I'm sorry. You, if I speak English, you'll have to use your headsets again.
I absolutely love the questions and and what I've learned. I will offer this. I totally get how what I could say could come across the wrong way. So just understand that. In 2010, in the United States, we brought the first group of people together to talk about medication-assisted treatment. Methadone, buprenorphine, Suboxone, and then eventually what would be Vivitrol, right? Those are the three medications for opioid use disorder. It was a calm, casual conversation. Over the next few years, we developed calm, casual conversations. And then the opioid epidemic hit, and the deaths from opioid overdose skyrocketed to 4 times what we'd ever seen. And then, and this is my comment to the French, my brothers and sisters in France, then everybody got on the bandwagon. The behavioral health treatment was behind the 8 ball, that American expression, behind the 8 ball, and got forced by law enforcement and by policymakers to move in ways they didn't want to. And so what I offer is, if, as Dr. Gozlan said, your opioid deaths are rising. I hope that does not continue, but if it does, the urgency of that will force your hand as behavioral health providers to act and to be ready and get going, because that's what's happened in the U.S. All these calm, very good conversations are no more. It is the police chief saying, get going. I got 20 people dying. It is the elected officials saying, get going, behavioral health. I don't care about your conversations. I don't care what you think is the best treatment. People are dying. And because they're dying, I need an answer. And that is what's happened in the United States now. Behavioral health is barely in the conversation. I'm not saying that would happen here, barely in it, because people are dying at rates that exceed HIV/AIDS, handguns, and alcohol. Please don't get yourself in that situation. Whatever it is, figure it out beforehand, because when it comes, you know what it's going to be like. You're at fault, your problem, fix it fast. So thank you for having me. I know that's a horrible way to leave.
Merci, Jack. Merci à vous tous d'avoir tenu bon.
Thank you for everyone. Thanks for holding out until now. It was a rich, intense, and dense day. We'll be back this time next year. Thank you to all.